Welcome to the Food Junkies podcast. Here, we aim to provide you with the experience, strength, and hope of professionals actively working on the front lines in the field of food addiction. The purpose of our show is to educate you, the listener, and increase overall awareness about food addiction as a disease with abstinence as the solution. Here, we talk about all things recovery. Most importantly, how to thrive rather than just survive. So stay positive, make a change for yourself, tell others about your change, and hopefully the message will spread.
Welcome to today's episode of Food Junkies. I'm Molly Painschab, and I am joined today by Dr. Vera Tarman and our guest, Dr. Marty Lerner. Dr. Lerner is the founder and CEO of the Milestones in Recovery Eating Disorder program located in Cooper City, Florida. A graduate of Nova Southeastern University, Dr. Lerner is a licensed and board-certified clinical psychologist who has specialized in the treatment of eating disorders since 1980. He's appeared on numerous national television and radio programs that include the NPR Report, 2020, Discovery Health, ABC's Nightline, as well as having authored several publications related to eating disorders. He's an active professional member within several associations, and we are just so delighted to have him here with us today. So welcome, Dr. Lerner. Hi, welcome to today's episode of Food Junkies. I'm Molly Painschab. I'm here with Dr. Vera Tarman and our guest, Dr. Marty Lerner. So Vera, take it away.
Okay, welcome, Dr. Marty Lerner. So just for those of you who don't know who this giant in the industry is, Dr. Lerner is the CEO of Milestones in Recovery, which is a U.S. residential treatment center for people with eating disorders, and uniquely, and that's why I'm saying that he's a giant, in the field of food addiction for many years. So he's been working in the field intersecting food addiction and eating disorders since what? Since the 1980s, Marty?
I think so, yeah, since 1981, actually.
And the reason why I think this is such a big deal is that in the 1980s, the field of disordered eating was more or less dominated or started in the eating disorder field, and then that field dominated it. But Marty, you brought in the whole concept of food addiction gradually more and more until now. I think you deal with it pretty prominently. But I'm going to let you take the floor. Can you give a tiny bit of history about what it was like in the 80s and sort of what it is like now and where you fit into that story?
Sure. I'll try and do I like to say the Reader's Digest condensed version of all of this. So yes, I've been doing this for more years than sometimes I realize, so it really dates me. I will say that there were motorized vehicles at the time and not dinosaurs when I started out. So that said, when I started, basically it really started for me while I was in school, and I was doing some research on the regulation of appetite and food regulation and dealing with it from the standpoint of brain anatomy and insulin levels and so on and so forth. Anyway, making this longer story a little bit shorter, I asked for some subjects that had formerly had problems with their weight. In other words, formerly obese people, as well as people that never had a problem with their weight, and people that were currently overweight. And what I found, to my surprise, this was in the mid to late 70s, we used college students as subjects, which we all know college students are very available and willing subjects. And there were a number of women who were formerly overweight, who I later found out in the research were using different things to compensate for overeating. And so the language was not about binge eating or binge eating disorder or bulimia, was just being coined a term from Europe and on and on and on. So that was my introduction into, this culture, this world that, I really didn't know existed. And so that was how it evolved for me.
Just for people listening, you were an academic psychologist, right?
Right. I was in a university in a graduate program studying my PhD, for my PhD, and doing research in the field. Yes. And so from that, I graduated. And also graduated from laboratory animals to human beings, I'm proud to say, and got more and more involved published a few, obscure papers as part of the requirement. And then all of a sudden, there was this explosion either in the media or exposing the fact that there were a number of people, more than I think the public realized, that suffered from this thing called bulimia, compulsive overeating or binge eating, as well as anorexia. So the term eating disorders gained some level of acceptance. If we speed that up, I was involved in the treatment of these disorders in an academic setting, and then in a clinical setting was asked to set up a eating disorders unit in South Florida, and that was in 1982. So, and then from there went on. But what I also discovered was, going along with that, coinciding with those dates, I was also involved with sending patients who were overweight into Overeaters Anonymous. And then I also found, ancillary to all of this, that a number of those people were not overweight. As a matter of fact, a number of those people really suffered from bulimia, what I will call bulimorexia, which is really someone in my frame of reference that's anorectic but doesn't meet the weight criterion for anorexia, but uses compensatory behaviors like using laxatives or making themselves sick or exercising and things of that sort. So anyway, in 1983, I became familiar with a program at Glen Bay Hospital where another person, Phil Wardell and Marge Porter, were involved.
Yeah.
You didn't know all this. All right. So they were in Tampa, and I was asked to direct their unit for eating disorders in Miami. And what we were seeing is the majority of people that were being solicited for and coming in for help really suffered from overeating, whether they were underweight, normal weight, or overweight. So a sidebar to all this, in my world, the poorest definition of an eating disorder is what someone looks like or what they weigh. Same thing for alcoholism. People who suffer from addiction, you're not going to normally pick out of a crowd. So I did not know Phil. I did not know Marge, other than their names, and that they were, involved in the work in Tampa, Florida, and I was in Miami, Florida. And I was introduced into the world of food addiction. So the term food addiction to this day still struggles to be accepted as a legitimate concept, just like years and years ago, the term drug addiction, was not synonymous with the way it is today. So when you say drug addict, you really are thinking of someone who is dependent on, addictive drugs, nature of the person, but also the nature of the substance, whether those are opiates or powder form or cocaine or whatever. And food addiction has yet to be looked upon in that light as well. Is it possible to be addicted to food? Well, not all drugs are addictive. Like, people aren't usually addicted to aspirin or vitamin pills or other, non-controlled substances. Well, not all foods are addictive. So that's where we are today. There's a growing contingent of people that are familiar with the term food addiction. So when they hear that term, it has a whole different meaning and history and experience for them than when the average Joe out there or Jane out there hears the term food addiction. They usually will scoff and say, well, how can you be addicted to food?
Yeah, but Marty, you've been saying this like long before we've even been thinking about it. Like you were starting to treat people with as food addicts like 10, 20 years ago, right?
I hate to say this, but it was more like 30 to 35 years ago.
Yeah. Okay. So
oh my God, I'm on Medicare. It's so sad. Anyway, for a long time, but I'm not the originator of the term food addiction. So whatever I have accumulated in terms of experiences and knowledge and whatnot, to be cliche, has been on the shoulders of other people who came before me. And those people are like recovering alcoholics. We owe a great debt to the people who started AA and so on and so forth. So really, the shoulders I speak of are people that are recovering from food addiction and eating disorders. And tradition forbids me from naming names, but those people are also crossed over into being professionals in the field. Just like there are many professionals that are addictionologists or physicians that have recovered that specialize in treating alcohol dependency and drug dependency, and hopefully some of us who are treating food addiction.
Yeah, I think you should be acknowledged, Marty, because you are a clinical psychologist working in eating disorder, when eating disorder professionals generally really disparage the concept of food addiction, but you were taking that on. So, I mean, yes, there were other giants in the field, but you were in the eating disorder field as somebody who held your ground. And I mean, that's I think incredible, because we're still struggling with that battle today. Wouldn't you agree?
Yes. Absolutely. And I appreciate the accolade and the acknowledgement, although I don't think of myself in that light, but I appreciate hearing that. It is very validating on a personal note to be speaking today with more acceptance and more of my peers and more people kind of, seeing what a lot of us, were experiencing and seeing years ago. So, I'll just use this as a sidebar, analogy. It's also very validating that with and I'm sure you know this, Vera, but with the technology now, with functional MRIs and tomography and so on and so forth, we're able to see how close these people in 1939 who were looking at addiction in the wider scope of things as a disease and then as a brain disease, and now are validated by the science. So the science has been catching up with the experiential and anecdotal pieces to the people whose shoulders, yes, I'm on, and maybe someone's on my shoulders. Okay, we're all standing side by side. I'll take it that way. But anyway, so it is very validating, to look at that. But now it's not anecdotal. It's real. It's evidence-based. It's science, and addiction is real, just like drug addiction is real, and alcohol dependence is real. We now know that food addiction is real. And we also know that what people are labeling as process addictions or behavioral addictions, like compulsive gambling or sex addiction, and so on and so forth, that's real too, because the behaviors psychosomatically influence the biology, and the biology can also dictate the behavior. So I don't think we have to, split hairs.
Yeah, Marty, since you mentioned the concept of process addiction, let me just jump in and ask you, do you think that the whole idea of compulsive eating, not actually the substance, but the behavior of eating, like anorexic or bulimic, can actually be addictive, like seen as a process addiction?
Yeah, I remember our conversation in one of the conferences, because I had mentioned anorexia and bulimia. So one of the things, as a product of my own experience, in the field, is I don't delineate between anorexia, bulimia, compulsive overeating, and food addiction. They overlap so much that in my world, I see them all as addictive processes.
Okay.
And the neural pathways and reward systems that we're both familiar with are identical. And some of the research is just showing that the subjective experience, let's say, of eating may be like a roller coaster ride, the way I look at it. Some people experience a roller coaster ride as exciting, and other people like me have a panic attack. And some people experience eating as pleasurable and rewarding, and there's a small contingent of people that experience it not as rewarding and exciting, but as terrifying. And we can go on and on and on. So there's the nature of the person, the biology, and the setting. But when you look at food addiction, I cast a wider net than the average person out there, because I tend to include the other patterns of eating within that scope, just like I wouldn't define a compulsive overeater or binge eater or food addict as being overweight, because they can be just, they can be normal weight or underweight.
So the idea of, I think it's called orthorexia, where you overeat unhealthy foods, that would fit into that whole continuum as well, right?
And exercise addiction, and then men have their own flavor with working out, and then a subset of steroid addiction, and then for me, not all. A lot of patients that I see all claim to be ADHD, so they could take Adderall. It's endless. It's endless.
Okay, so if you're calling it all sort of under the same umbrella or continuum, one of the reasons why the distinction is useful is because of the treatment. So if I buy the eating disorder model, we're going to have the whole moderation thing. We want to be able to just eat normally once we deal with the psychic distress. But with food addiction, we don't believe in that. We believe in abstinence of trigger foods. So would you then, in your work with your umbrella, tell everybody that they have to be abstinent?
No, there's no black and white. Part of the problem in addiction is dichotomous perception and thinking. It's either or. One size doesn't fit all. I did write a paper about what's the difference between what we're talking about, an eating disorder and food addiction.
Exactly.
And the easiest way for me to put this is that, and this is a generalization, and whenever you espouse a generalization, the exception always stands in front of you and makes you look silly. But that being the case, I would say that as a rule, if you have genuine food addiction, the nature of the substance or the nature of the foods, there is no negotiating. It's abstinence. As an alcoholic needs to abstain from the substance alcohol, a food addict needs to identify and abstain from their substances. Most of the time, that's refined carbohydrates like sugar and flour, and then you can expand upon that. It does bleed into trigger foods, but for the most part, it's a total abstinent prescription as part of the recovery process. With eating disorders, there are exceptions to this rule. There are people who can tolerate certain foods, and the nature of the substance isn't addicting. Let me give you an analogy, but there's a high probability that you're not going to know. So there's a little bit of risk factor. Yeah. So if an alcoholic, some alcoholics in AA may be oblivious to taking a pain medicine like Percocet or a benzodiazepine medication, and they don't cross-addict to it. But it's high risk. But the majority of people with alcoholism would not be wise to take substances like that. Yeah. And if you have an eating disorder like anorexia or bulimia, the exception may be restricting anorexia. But if you're a purger or overeater and anorectic, you have a propensity towards being sensitive physically to these substances that a food addict would be. Yeah. So a lot of people with eating disorders do well on an abstinent or a whole food or non-processed food or however, a prescribed food plan. There are a minority, and I say minority, but I can't quantify it, of people with eating disorders where most, if not all, of their eating disorder is emotionally triggered and doesn't have the physical component. Just like there may be some people who binge drink but aren't really alcoholics. Maybe they're more, but it's so hard to tease out. The question I ask myself is, what harm do I do if I prescribe or suggest, a whole food plan? Because if we were eating like it was 200 years ago, this wouldn't be a conversation.
Yeah.
So anyway, I wish it was as clean, and there weren't exceptions, but there are. So one of the things about treating food addiction and or eating disorders, I think, and I'm sure you'll all agree, is one size doesn't fit all. You have to individualize what is an abstinent food plan. The one thing I would say is almost without exception, it includes sugar and all the cousins that are processed around sugar, from dextrose to fructose to fructose and whatever else is out there. But then when you get into flour, is it white flour? Is it whole grain? Do you get into, some people get to the point where it is orthorexic, or it's an exhaustive list and unlivable. And other people go, I can eat Fritos and still be abstinent. So there's something in the middle. So I think being a dietitian in this field is more an art form than a science sometimes.
Well, yeah, and this is the reason why we have such a struggle with the DSM-5 submission. Like, what do we say? Because there's nothing clear, and that's what they want is clarity.
And then you have people, on board that and their intentions and their experiences are really well intended, who want to just do a keto variant. And I go back long enough that I was running around the halls of my high school with keto sticks, showing everybody I was turning purple. So Atkins came around twice. He first came around in the 70s, then he died down, and then he came back, and then he slipped on the ice, and that was the end of him. And then now we have, if you stay in this field long enough and you don't die, everything circles back in terms of a fad. So fats are bad, and then fats are good, and then on and on and on. Eggs are bad, now they're good. You'll go crazy with all of this. The reality is, as a rule, the one thing that I don't think has changed when you look at the nature of food is that, for the most part, things that aren't processed tend to be safer than things that are processed.
Yeah, right on. And so let's look at the clinical work. So you have this program, Milestones in Recovery, eating disorder program, which embraces food addiction. So tell us what that looks like.
Oh my gosh. Okay. So I'll do a little self-disclosure going back a little bit.
Okay.
In the early 80s, when I was giving a little bit of my history, I look at addiction as a generic term. So on a personal note, I was reared in school in academic research, but I also, in therapy and all of that, had a few mentors that were more on the Carl Jung analytic persuasion.
Yeah.
So for them, a cigar is not always, a cigar is not just a cigar. I don't know, I ran down the street screaming when I understood what an edible complex meant, and I couldn't handle it anyway. So when I was dealing with my own stuff, I suffered with juvenile onset obesity. So eating disorders weren't a term. So I was reared on medication for that, and so on and so forth. So my own recovery was a combination of OA attendance and AA attendance. And speeding this tape up before Glen Bay, I was involved in IDAA, which is International Doctors and Alcoholics Anonymous, and PRM, which is the Physicians Recovery Network in Florida.
Those guys too.
And just to be clear, I was drafted. I didn't volunteer into the program. I was their number 2 pick. My roommate in treatment was Dr. Denial. He was in number 1 pick. Anyway, I was in a program in Hattiesburg, Mississippi. It was a sister program to Ridgeview, and a man named Dr. Talbert. And so that program was a 6-month-long program that's identical to the one I came back and started, which is now Milestones. So I took that formula and transposed it into treating food addiction. Bottom line. The difference, though, is that there are more similarities than differences, but folks with eating disorders and food addiction, the ego structure is a little bit different. So there is a tearing down of the ego. I'm getting a little technical when you treat a lot of addicted docs, because they walk on water, as well as egomaniacs with inferiority complexes. But people with food addiction, I don't see that as much. So you need to be careful that you're not shaming people, and so that they're in an environment that's more supportive, less restrictive, more structured, but at the same time addresses some of the scar tissue and trauma that usually comes hand in hand with eating disorders, and is a little bit different from the chemical dependency world. Although I would say half the people we see come to us having been treated for chemical dependent problems, because it's rare to see someone with only one addiction. So Milestones is what I call in vivo from the research language. Most treatment programs are in vitro. They're artificial. Anybody could be locked, given a food tray, told to eat this much or not eat more than this and be controlled. And in vivo is real world. So people live in apartments. We try to make a therapeutic community where they're learning to depend on each other rather than professionals. Attend support groups. They go grocery shopping. They learn how to prepare abstinent meals. So we do things so that the last day that they're with us and the next day when they step down or go into their home environment is as seamless as possible. And that was my experience when I went through treatment, for alcohol and prescription meds.
And now with the whole virtual world, are you doing the same thing now virtually or as much as you can?
It's amazing. I mean, there are silver linings in all of this, but we're able to treat more people than we ever dreamed would be possible because not everybody can go away to treatment.
Yeah.
And number one. And number two, in the virtual world, you can do and reach more people. So I hope they keep the rules the same because I can treat someone, in Oregon, without having to have our residential license in Oregon or have them leave their families to come to us. And when people are with us and they go home, they can stay, in treatment in IOP or PHP, meaning they can be with us. They can share meals together if they have a tablet. So we have tablets now, iPads in the apartment, so people can join in from home and eat together. Because addiction is an isolating disease. So if you're able to eat together and accountable, you're not as triggered to overeat as you would if you're by yourself.
And since they're no longer in the residence eating the food that you're giving them, that are you able to somehow determine that they are eating the right foods
for the most part, Vera. But remember that we're not really feeding them. So from the get-go, they're grocery shopping. They meet with a dietitian and they learn what an abstinent food plan is. And we pair them up with a mentor in the apartment. And so they learn how to cook abstinent food. Now we have enough alumni that we have alumni come in twice a week and do cooking classes. And we have a recipe book. It's really neat because otherwise people like me, to be honest with you, we'd eat tuna salad 7 days a week or the same foods or get a comfort. And there's a whole creative world out there to make abstinent eating fun and delicious.
Right.
So there's that part of it. But I think the other part is regardless of the food, if it's abstinent, being in a community where you can eat together is different than other addictions, because when people are able to do that and be with like-minded people, it has a therapeutic effect that's the professionals can't provide.
So in 2020, a day in the life of Milestones, would I still be going to an apartment on your setting, or is it all virtual? And so I'm in meetings Zoom meetings the whole day.
Oh no, we have people that are live. You mean, are there people that are there in residence?
Yeah.
Oh yeah, I'm sorry. Yes, we limit that because of COVID. So our protocol is they need to be COVID tested within 24 hours of admission. Then they practice CDC guidelines during their first 5 days, and they're COVID tested at the end of 5 days. And then we have a ceremony. We usually do a human sacrifice every Tuesday. Just kidding. That's usually a staff member.
Yeah.
But anyway, so but the numbers are much less than they were.
Yeah.
But there's a collateral benefit to that because it's a much more intense system. Yeah. And then the numbers are much greater on the telehealth side of the spectrum. Right. So there's a balancing of all of that.
And is that like a mixed thing, so that if I'm sitting telehealth, somebody else might be actually there in person, so that in a room where there's both happening?
Yeah, it's simultaneous in real time. In
Okay,
other
good.
words, if it were, what time is it now? Okay, so it's almost 6 o'clock Eastern time.
Yeah.
So people would be calling in on the Zoom room, the Milestone Zoom room, and
Ah,
there would be tablets, in the apartments, and
wow.
everybody would be eating dinner together. You'd
Yeah,
have 6 people, let's say, in residence,
yeah,
going to an apartment, having dinner at
yeah,
Milestones at the
yeah,
residences, and then you'd have someone from, on the Eastern Seaboard having dinner, maybe a couple in Pennsylvania, maybe
yeah.
a couple, of people, different places, and you'd have maybe 10 people, 15 people having dinner.
Right.
And then we have an alumni big book meeting. Then we
Oh,
have,
wow.
it's,
Yeah.
it's just, it has a life of its own.
Yeah. Okay. Good. Thank you. That's interesting how you can actually still do a program despite the challenges of 2020. Okay. So one of the questions I had is, if a person can't afford inpatient care, is there stuff that they can do, like, or even just follow up, like after they've done the program and they want to still
Yeah. Yeah.
hang in? Yeah.
So,
That's like, what's your aftercare program like? Or
yeah, we have an alumni program. So
yeah.
we do meetings that are not OA meetings, but we do our own, alumni get involved in doing a big book meeting.
Okay.
One of the issues, this is a sidebar thing, is I don't want people doing food addiction treatment as a food plan only.
Yes.
Recovery is much more than that. So
Right
we
on.
try to embellish beyond the food. So
Good.
there's a big book meeting. Then there's also a weekly Sunday night alumni meeting, and they get together. There are plenty of resources. The problem isn't the resources, it's getting people to follow through and
Yeah.
not just make this a weight program and
Yeah.
not just make this an abstinent food program. So there's that piece. People can see the therapist that they worked with as their primary therapist at Milestones individually. If people don't have funds, we educate them on how to get insurance. Hopefully, this will change with the new administration. Hopefully, well, I won't get political. Anyway, we have new people, and it's a new day, so I'm hopeful. And but even if people don't have insurance or they don't have funds, we resource them to OA groups. We also have a mentor program where we can hook them up with someone who's been through Milestones.
Yeah.
And to be honest with you, like all of us, if we think someone's really motivated and they're persistent enough, they find a way. I don't know how else to put that. We can't offer free treatment, but we don't turn people away. I don't know how else to put that. And there's more latitude with telehealth than we had when it was, face to face.
Yeah. Okay. Now, Marty, I got a couple of terms. If you could just define a constructive living model, what does that mean?
Wow. Okay.
That's a big question, is it?
No, I can distill it. In Western psychology, psychiatry, and therapy, the holy grail has usually been feelings. How do you feel about that? And getting in touch with your feelings. So, in my experience, most people with addictions are not out of touch with their feelings. They just don't want any part of them.
Yeah.
I find that's true with addictions.
Yeah.
So I don't know it's about beating up a pillow that looks like your mother. So constructive living came from a professor of psychiatry who's really an anthropologist, David Reynolds. He teaches at the medical school at UCLA. And I met him while I was doing hard time in treatment myself. And he turned me on. He's not an addictionologist. He turned me on to how Eastern philosophy and how that integrates into Eastern psychiatry. And the mantra there is, you are what you do, not what you think or feel. Okay. So in Western, it's let's change your thinking, cognitive behavioral, that'll change your feelings, and maybe it'll change what you do. Or it's let's talk about your feelings, and if your feelings can be identified, then your thinking will change, and then maybe your behavior will change. I've never seen an addict get well by making as a condition of their abstinence feeling different or thinking different.
Right.
You'd have to do different.
Yeah.
So constructive living is about putting the horse before the cart. Okay. So it's basically that your feelings are not going to be controlled by your will, and your thoughts maybe you can influence, but that's not going to be controlled by your will. That the only thing you really have control over is what you do. And the only exceptions to that are biological processes like stopping your breathing for 10 minutes. So that's a very simplified version of this. but it's a blend of Eastern philosophy, Eastern psychiatry, and common sense.
Okay. It's also AA in the sense, or 12-step in the sense that we say act as if, right?
Oh boy, could I get in on this? Bill Wilson, unbeknownst to a lot of people, if you really get into him,
Yeah.
had it was more Eastern philosophy in the 12 steps than people realize.
Oh,
Although it had a lot of Judeo-Christian
I
elements
know.
to it
That's
and a
what people
lot of
criticize.
evangelical, you're
Yeah.
talking about a guy or a group of people, or I don't know, who were more in prayer and meditation. I mean, this guy also was doing, oh God, before Nixon came in office, was doing a lot of therapeutic, not recreational work with psilocybin and LSD.
Yeah.
And it had profound effects in the treatment of alcoholism. Now, John Hopkins and a few other places are picking up on that and using it, therapeutically and MDMA. I won't get into all of this, but it's following science. It's not in the service of recreation. So his flavors of spirituality and his flavors of understanding the 12 steps and how it all evolved have elements that go beyond just Western culture.
Okay.
I'm impressed.
Okay, so thank you. In another sort of area, treatment success. What's your definition of that?
Yeah, that's a tough question. In the world of research and science, it's a tough one, because in the whole world of addiction and mental health, you're dealing with self-report. So if I could take a blood sample and then tell you, well, this element, shows before and after. It's very hard to do. So when you're relying on self-report, you get an exaggeration of success. So if you do a telephone survey to alcoholics, no, decent recovering alcoholic, or recovered alcoholic or relapsing alcoholic is going to be totally honest. So you're going to get people that are so ashamed if they've relapsed, they won't tell you, or they won't participate. And those that are successful will participate. So if I said to you, of those people who returned surveys or responded, the success rate is like 88%, it's a false number. However, what I would say is that the attempts to look at success rates in AA and NA and those programs, they vary widely, but I would say it's probably similar to those programs. But I will say this, it's probably over 80%, if not higher, of those people that continue to participate in some recovery activities.
Right. So basically it works if you work it, and you have to work it.
That, it's not a scientific, statistic, but it's the most honest one I can give.
Yeah.
And for me personally and professionally, the way I deal with that is by seeing with my own eyes the people who are sitting in the Zoom meetings or in the face-to-face meetings or that I interact with. I mean, that's, but I don't know, I don't think anybody has an accurate number.
Yeah. Okay. It does strike me as I might be being unfair here, but the success rate, if you work it, seems to be more successful than eating disorders, where there's a high recidivism rate. My guess is because we're not catching the food addiction piece in that. Yeah.
Yeah, I think you're right. And I think it used to be that way with alcoholism, in the 80s and whatnot, because then it was anything goes. I mean, there were heroin programs like Phoenix House that used to tell heroin addicts who were recovering, you can drink alcohol.
Yeah, right.
Yeah,
okay.
You're right. That if you're not addressing the emotional as well as the physical as well as the spiritual components, and you're addressing this as the eating problem only or the depression and eating problem only, you'll have a much higher relapse rate than if you're casting a wider net.
Yeah. So just in summary, from what you're offering is you're coming from an eating disorder model, imposing on that the addiction model and making the umbrella bigger. And within that, there's this spiritual piece, this Eastern piece that you're also embracing. And that's, if we do all of that, it can be an 80% success rate.
I think so. And I would just add one asterisk to that, and that is that you need to keep an open mind. So you need a staff that's not going to shame people if they're still abstinent from their eating disorder behavior, but are eating foods that are not typically thought of as abstinent.
Right.
So you don't want to shame people if something's working for them, although they have to understand the risks any more than I would want to shame someone in another fellowship if they were taking a medication that I didn't agree with.
Yeah. Okay. Right. Okay. Because they may be part of that minority where it does work.
Yeah.
And that's good, Marty, for me to hear that, because I do tend to be kind of rigid on that. And you're right. There are people who can. Okay. So Molly, did you want to take the signature question to sort of close us up here?
Yeah, absolutely. I just want to make one comment about, you guys having that conversation about, the like recovery stuff. Like it can't just be about food plan, weight plan. There also has to be this recovery thing. And as a licensed mental health clinician and a licensed addiction counselor myself, my anecdotal experience has also been my clients who come to me with alcohol, heroin, meth, I don't care what it is, food, trauma, all the things. If they are doing a 12-step program, as well as working with myself or any other professional in the community, their recovery, their success, however we want to label that, is so much bigger, better than anybody who's just coming to me once a week and can't get abstinent or can't get, more than a few days at a time strung together. When they're working that 12-step program, when I can say, wow, what would your sponsor say about that? Or, have you called anybody? Or when was the last time you were to a meeting? Or what does the book say about that? But when I can use that as a tool with my clients and just kind of give it back to them, like they have to go back and they have to look at that and they grow and then they're coming back and they're like, wow, that I talked to my sponsor about that, or I called somebody in program about that. And I didn't pick up since I talked to you last.
Yeah.
Right. So because they're reaching out and when they're doing that work. So I just want to say, thank you so much for pointing that out. I think that's huge, that we have to have treatment and recovery.
You make a very, very, very important point. We need to treat, but also speak 3 languages. And the 3 languages that we need to speak is our professional language, as our licenses and training have provided, but also recovery speak and understand it. And the 3rd language, at least in this country, is insurance speak.
Yeah, there's that too.
Yes, they're suicidal and about to jump off the roof, but whatever. But you know what I mean. So, and then because we're talking to different audiences at different times.
Yeah, absolutely. Thank you so much for kind of just putting the nice little bow on that for us, for sure. So our signature question, the thing we want to know from all of our guests is, if you could tell a younger version of yourself, even if it's just a 5-minute ago younger version of yourself, right? Something about food addiction or food recovery, what would it be?
What would I tell myself? Oh, okay. I would try and frame it in terms of my having a disease and not a shortcoming of my character or lack of willpower, and try to do battle with the voice in me that calls it shameful, and try to tap into the voice in me that acknowledges and begins to accept that it's a disease that has a treatment that's available, and use some kind of compassion towards being imperfect. Because I grew up, and again, I don't mind saying this, as a form of self-disclosure, if it'll help somebody. I mean, I grew up hating my body and hating that I was doing something that I didn't want to do. For addiction, for me, the Kodak moment was standing in front of a refrigerator, hating my body while I was eating when I really didn't want to eat. And I didn't learn until later on in recovery what that was about. So that piece is what I would like to go back and take that kid and say, it's not you. You're sick, and and this is what you need to do to get better. So that's what I would like to go back and redo.
Okay, well, thank you so much, Dr. Marty Lerner. Just for those of you who are listening, a reminder, Dr. Marty Lerner is the CEO of Milestones in Recovery and has been working for, I guess, almost 40 years I know, it's a scary
I
thought.
started when I was 6.
Working in the field of eating disorders and food addiction all this time. And so he's speaking from personal and professional experience. Thank you so much, Marty, for joining us on this.
I'm so glad I didn't miss this, and I really enjoyed talking to you guys. I need to be in touch with people in my tribe. That's the best way I can put it. It keeps me going. So thank you very much for the opportunity.
Okay, thank you.
Oh, and Marty, one last thing, and we'll definitely put it in the show notes. But if people want to what's the best way for people to get a hold of you or find your information?
There are 2 things I would say. One is, go to the website like everybody else. It's Milestones Program, Milestones plural, program, one word, .org. And after you read Vera's book and her newest book, you can read my book, but you have to read hers first. And
what do you have?
Anyway, you could get it as an ebook. It's not like something that's widely distributed. It's just something that's available. It's my playbook.
Okay.
So it's a distillation of everything you're hearing me talk about. And that's the best way to get in touch. And then, we'll go from there.
Okay. Thank you so much.
Thanks for joining us this week on Food Junkies, Recovery from Food Addiction. Make sure to join our Facebook group, Sugar Free for Life support group, I'm Sweet Enough. You can subscribe to our show in iTunes or Stitchers. That way you'll never miss an episode. While you're at it, if you found value in this show, we'd appreciate a rating on iTunes. Or if you'd simply tell a friend about the show, that would help us out too. Don't forget to pick up your copy of Dr. Tarman's book, Food Junkies, which is available on Amazon. If you have any additional questions, both Molly and Clarissa are food addiction professionals and work one-on-one with clients. You can find their websites and email addresses in the show notes. Be sure to tune in every Friday when our new episodes drop. As Vera loves to say, the power is ours.